Assalamualaikum dear doctors. In this video I am discussing about Myasthenia gravis, its history taking and discussion everything. So first we know the Myasthenia gravis. So Myasthenia gravis we know it's an autoimmune disorder. Antibodies against the acetylcholine receptors. There is antibodies are produced by the B lymphocytes. Thymic hyperplasia is observed in about 65% and thymomas in 10% of Myasthenia gravis patients. Clinical features. How they are presenting, that is 6D. Easy to remember. Remember there is diplopia, dysarthria, dysphagia, dyspnea, descending weakness, deep tendon reflex are preserved, snarling faces, nasal voice, nasal regurgitation. So we know that eyelid dropping, then voice change, difficulty in swallowing, difficulty in deglutitions, very much fatigue. These are the features and complaints of Myasthenia gravis patient. Investigation, what we do, that is anti-receptor blocking antibody, anti-mask antibody, anti-LRP4 antibody, repetitive nerve stimulation test, adrophonium test, CT MRI and CT chest, pulmonary function test. Treatment, what treatment we give in Myasthenia gravis, that is anticholinesterase inhibitor, thymectomy, immunosuppressions, treatment of myasthenic crisis. Remember, the diagnosis is adrophonium is for diagnosis and pyridostigmine is to get rid of symptoms. For the history of Myasthenia gravis come on exam. The exam scenario is that 7 years old with history of fatigability, reduced exercise tolerance and recurrent chest infections. Take the history. So we know that fatigability is one of the features and that is with day progressive. Like evening time the fatigability is increased. Now I am taking the history. Introduction is similar, everything. History of present illness, we complaint analysis plus CNS, musculoskeletal system and other systemic view. First are they started together or one by one, then start with the serious one first. Onset, when it started, the course and duration, how long the patient is suffering this problem, is there any triggering factor that increase or decrease. Timing is very important in Myasthenia gravis. At the end of the day, increase with fatigue, tiredness and stress, relieved by rest. Remember, Myasthenia gravis at the end of the day, that is increased with fatigue, tiredness, stress and relieved by rest. Then site of the weakness, is it unilateral or bilateral, where starts first, does she have weakness in going up and down stairs, any weakness on combing her hair, any abnormal gait, any abnormal movement, any behavioral changes, any abnormalities in the eye. Remember droopy eyelid we find in Myasthenia gravis. So any abnormality in eye we ask, any concern regarding visions, diplopia we find in Myasthenia gravis. Then we ask any redness or puffiness, asymmetry of the face, any concern regarding her hearing. What about her sensation? If you but something cold, can she felt it? Is it associated with headache, any morning vomiting? What about her way of talking? Because we know Myasthenia gravis we find nasal sound interrupted, understandable, occur at certain time and dysarthria. Any problem in swallowing of fluids and solids? Because dysphagia is a features of Myasthenia gravis. Then FWASL, we know that fever, weight loss, activity, sleep, lymph nodes. Any concern, any other, we ask. Any chronic illness or long-term medical conditions, maybe with other autoimmune disease. Remember, in Myasthenia gravis patient history can be there is other autoimmune disease present. Like example, Addison's disease can be present. Then systemic review, musculoskeletal, we ask any skin spots, any swelling, any part of the body, any hyperpigmented lesions in the body like vitiligo, any hair loss, alopecia presence or not, we exclude. Then chest, recurrent bugs infection, cough, how many pillows using during sleep. Recurrent bugs infection present on Myasthenia gravis patients, alopecia present, vitiligo patient, we should need to exclude. CVS, we ask heart racing, exercise intolerance, chest pain or shortness of breathing, especially on lying down, fainting attack. Remember, exercise intolerance develop in Myasthenia gravis. From CBS, we rule out that. Then GIT, we ask tummy size, tummy pain, throwing up, describe for me his poo, loose or constipations, yellowish discolorations. Then urinary P concern, that is there any polyuria, polydipsia to exclude the diabetes mellitus, anyone measure her blood pressure. So we know that Myasthenia gravis is an autoimmune conditions and other autoimmune conditions attached with it. So we exclude the diabetes mellitus by asking the P, that is polyuria, polydipsia, and loose or constipations by hypothyroidism we can exclude. Now from endocrine we can ask hot or cold intolerance, thyroid, any lump in the leg, anyone measure his blood sugar. So hot or cold intolerance by asking we exclude the thyroid disease. Hematology, any pale recurrent bugs in the body, swollen glands in the neck, numbness, the fingers, pernicious anemia we exclude. In past history, we ask 5T IOA. 5T we know that is details we ask any trauma, treatment previous, any traveling history, any blood transfusions and which team is involved in the treatment we will ask. Then IOA. IOA, we know that the short form, that is IOA is investigations and onset and admission in previous will ask in details in past history. Then ask about the head trauma, drugs. If he is chronic case, ask about his medications, compliance and drug level. Other drug which may interfere with his conditions, beta blockers, azathioprine, ciprofloxacin, nalidixic acid, neuropsychiatric drugs and penicillamine, gentamicin. This drug will ask. Previous conditions. If any previous condition present, then when discovered, by whom, how it was presented, is it admitted to hospital in normal ward or ICU, for how long, what they did for him, how long he stayed. After discharge, any medicine was given to him, did you follow with any team. Then previous hospitalization we ask, in normal ward or ICU admitted, what done, investigations and medications given on admissions, which team following with. Then perinatal, natal and postnatal history will ask like fetal movements during pregnancy, amount of liquor around the baby, any feeding difficulties in early neonatal period, any admission to NICU. Then vaccination we ask, missed any shots, any extra shots. Allergy history will ask, nutrition history ask, development history will ask that is he looks like his peers in way of walking and talking. Then family history will ask consanguinity, how many children, history of similar conditions, history of deaths in the family, especially autoimmune disease, especially mother side. So other autoimmune disease history patient present on the family, we will exclude that. Then social and finance history, how did you do for living, is it satisfied for you, did you have an easy access to hospital, who take care of the other kids when you go to the hospital with, do you have insurance, receive any support. Social, psychological and impact will ask. If teenager, then social, psychological impact we totally ask. Now our discussion portion. Discussion the DD of myasthenia gravis, that is myopathy, DMD, Becker muscular dystrophy, juvenile dermatomyositis, hyperthyroidism, that is the DD. Then others, Guillain-Barré syndrome, neuromuscular disease, Horner syndrome. Drugs which that is botulinum, organophosphorus poisoning. Ptosis, bilateral ptosis, bilateral Noonan syndrome, Smith-Lemli-Opitz syndrome, Rubinstein type B, bilateral third cranial nerve palsy, migraine and craniocystinosis. Unilateral ptosis is idiopathic trauma, infection, tumor, retinoblastoma. Congenital ptosis, unilateral third cranial nerve palsy, Horner syndrome, Marcus-Gahn syndrome, local pressure on the eye. Now types of myasthenia gravis, that is neonatal, congenital and juvenile. Neonatal is transient, and this neonatal baby is born to mothers who have myasthenia gravis due to transfer of acetylcholine antibody from mother to child, presented early with floppiness, feeding difficulties, weak cry and difficulties in breathing. Antenatally, polyhydramnios with decreased fetal movements may develop deformities like arthrogryposis, improves within 4 to 8 weeks with anticholinesterase drugs. Then congenital myasthenia gravis, that is babies born to mothers who do not have the disease, defect in neuromuscular junction in the receptors. It's less severe but less responsive to treatment. Now juvenile myasthenia gravis, present after 10 years of old, more in females, same as adult type with fluctuating the fatigability. The investigation, what investigation we do for myasthenia gravis patient? Diagnosis is EMG, anti-acetylcholine receptor antibody, anti-muscle kinase antibody. Then lab we do ANA, anti-DNA, screen for other autoimmune diseases, imaging chest X-ray for thymus shadow, plus clinical test, that is androgen test, more than 2 years, positive if improvement for few seconds and disappear in minutes, done with precautions to be done at hospitals, 4-line ECG monitoring atropine. Less than 2 year neostigmine test with peak at 20 minutes. So androgen test we do more than 2 years of age, and less than 2 years we do the neostigmine test. Types of crisis. So myasthenia gravis crisis is 2 types. Number 1 is myasthenic crisis. Myasthenic crisis is acute respiratory failure, treatment with admission, IV immunoglobulin and plasmapheresis. And cholinergic crisis, overdose of medications, that is loose motion, lacrimation, salivation. Side effects of pyridostigmine, myosis, bronchospasm and emesis, treatment with atropine. Now treatment. What treatment we give in myasthenia gravis patient? Antimuscarinic we give neostigmine and pyridostigmine. Immunosuppressant we give steroids and azathioprine. Thymectomy. Indication for thymectomy is that if antibody positive, acute presentation, generalized affection with the pressure symptoms. Benefits of thymectomy is that reduce the dose of steroid and need for immunosuppressant decrease, need to go to hospital for crisis. New biological treatment, that is rituximab, belimumab, GCSF. Care of the coma patient. So who patient develop coma, how can we care? Admission to ICU. Diet modification plus feeding support. Pain management. Ventilatory support if indicated. Prevention of contractures, we give physiotherapy. Bed sores, frequent changing of the position. DVT, deep vein thrombosis, gradient pressure, stockings. Secondary infection, prophylactic antibiotics. Multidisciplinary team involved, we involve the neurologist, physiotherapist, immunologist, occupational therapist, salt for swallowing difficulties, social worker, dietitian, liaise with school. Now advice. What advice we give for myasthenia gravis patient? Number 1, wear bracelet. If in labor, a senior neonatologist should attend the labor as the baby may have congenital myasthenia and need respiratory support. Avoid triggers, stress, exhaustion and tiredness. Avoid some medications, that is beta blocker, azathioprine, ciprofloxacin, nalidixic acid, neuropsychiatric drugs, penicillamine, gentamicin. Educate parents about side effects of medicines. Emergency card plan. Give extra vaccines, that is pneumococcal and flu vaccine. Causes of respiratory failure in myasthenia gravis, that is myasthenic crisis, cholinergic crisis and respiratory infections. There are score they have given, score 0, 1, 2, 3. And talking, if talking normal then score is 0. 1 is intermittent slurring or nasal speech. 2 is constant slurring or nasal speech but can be understood. And score 3 is difficult to understand the speech. Now chewing, score 0 normal. Score 1 fatigue with solid food chewing. Score 2 chewing fatigue with salt food. Score 3 chewing, that is gastric tube. Now score 0 in swallowing, that is normal. Score 1 in swallowing, that is rare episode of choking. Score 2 in swallowing, frequent choking necessitating changes in diet. Score 3 swallowing is gastric tube. Now breathing normal is score 0. Breathing shortness of breath with exertion, that is score 1. Breathing shortness of breath at rest, score 2. Breathing shortness ventilator dependency, that is score 3. Now brushing teeth or hair. So brushing teeth or hair normal is score 0. Brushing teeth and hair extra effort but no rest periods needed, score 1. Brushing teeth or hair rest periods needed, then score 2. Brushing teeth or hair cannot do one of these functions, that is score 3. Now arising from the chair, score 0 is normal. Arising from the chair mild sometimes uses arms, that is score 1. Arising from the chair moderate always uses the arms, score 2. Arising from the chair severe requires assistance, that is score 3. Now double vision score 0 is normal. Double vision occurs but not daily, that is score 1. Double visions daily but not constant, score 2. Double vision constant, that is score 3. Then eyelid dropping score 0 is normal. Eyelid dropping occurs but not daily, that is score 1. Eyelid dropping daily but not constant, that is score 2. Eyelid dropping constant, that is score 3. So this is the score ranging of myasthenia gravis. This is all about total myasthenia gravis history, everything. Please do subscribe and share. MRCPCH with Dr. Amma Chaudhuri. Thank you.